Good afternoon, and welcome back to Grand Rounds today. Today I have the pleasure of introducing Dr. William Hogan. Dr. Hogan is an internist and hematologist oncologist. He attended to his postgraduate training at the Mayo Clinic, where he currently is an associate professor of medicine and also a consultant in the Department of Hematology Oncology. And he very graciously has accepted our invitation today to provide us with a review of the indications for stem cell transplantation. And please join me in welcoming Dr. Hogan.
Thank you very much, Dr. Holberg. It's a pleasure to be here. Thank you for inviting me. All right, I'll try and make it interactive. So if people have questions, feel free to interrupt. If it's not targeted to the audience, I think we have a relatively general audience, so I'll try and aim towards that. But if there are specific questions that come up, feel free to interrupt and we can chat specifically about that. So I thought we'd do a quick introduction to bone marrow transplant. My background is hematology, and I usually treat acute leukemia, myelodysplastic syndromes, bone marrow failure syndrome sometimes. And so my main focus is in allogeneic hematopoietic stem cell transplant. We also have a large autologous transplant program for patients with lymphoma, myeloma, and related disorders. But I'll focus less on that because it's a little outside of my current area. But if there are questions that come up there, I can try and answer those as well as needed. So quick overview of introduction to BMT. I don't really have any conflicts, but I was hoping to kind of quickly cover some of the major indications for bone marrow transplant, talk a little bit about donor selection criteria that we use, and then overall assessment, both from a disease standpoint and from a patient standpoint as to who might be a good candidate for transplant, especially allogeneic transplant, and some of the complexity that goes into that. For anybody that's thinking about referring a patient for bone marrow transplant, this is a very useful publication. It's from 2015, but still very relevant for most of the components. And this talks a little bit about the indications for autologous and allogeneic stem cell transplant. It has evolved a little bit since this publication, but this will give you a very good starting point as to where we stand for most diseases. And then there are obviously variations depending on the disease. But this kind of lists most of the hematologic malignancies and kind of what the role is for allogeneic and autologous transplant. And as you can see, an N means not generally recommended. Typically, we would not consider transplant in that situation. So for instance, acute myeloid leukemia in first remission that's low risk is usually not considered appropriate for allogeneic transplant because their likelihood of being cured with standard therapy is high enough that it doesn't justify undergoing allogeneic transplant. For autologous transplant, it's down as C, which is standard of care, but in fact, that's actually not that common now. And so for the most part, if patients with low risk, we wouldn't consider for transplant. If they're higher risk, intermediate or high risk, we would consider doing allogeneic transplant and not typically autologous transplant. So there are some components of this that are a little out of date or maybe not totally relevant with contemporary practice, but it's a reasonable place to at least start the discussion if you have a patient that you think might be a candidate. You can see all the other diseases as well, and I'll kind of touch on some of these as we go through with the various diseases. And so it's quite a comprehensive document that gives you a good idea of kind of where to start for most of our diseases. Just a little bit on stem cell mobilization. So for patients with autologous transplant, and the majority of patients for this are going to be patients with dysproteinemic disorders like multiple myeloma or systemic amyloidosis or Hodgkin's or non-Hodgkin's lymphomas. And that's probably about 3/4 of the patients that we consider for transplant here, and then about 1/4 or acute leukemias, bone marrow failure syndromes, myelodysplastic syndromes, myelofibrosis, maybe CLL, which is becoming quite rare for transplant now for allogeneic transplant. For autologous transplant, we need to collect stem cells, give the patient high-dose chemotherapy, and then reinfuse the stem cells after they have received the high-dose chemotherapy. The idea there being that we can escalate the amount of chemotherapy by about 3-fold because the stem cells are the most sensitive to the chemotherapy. And by removing and freezing the stem cells, that allows us to escalate maybe 2 to 3 times the intensity of the chemotherapy because the other organs, such as the kidney and liver, can tolerate that. And that allows us to kill leukemia or myeloma or lymphoma cells that may not otherwise be impacted by the intensity of the chemotherapy. So 90% of what is involved in autologous transplant is usually intensifying the chemotherapy to try and treat the disease in that fashion. There is some evidence to say that there may be an immune effect from the autograft as well, based on NK cells and the constitution of the graft that we put back in. And if there are questions or thoughts on that, we can certainly chat about it a little bit more at the end. But for the bottom line, for stem cell mobilization for autologous transplants, predominantly we use GCSF or GMCSF, or mostly GCSF now, and collect cells using that. So we give GCSF, collect the cells by leukapheresis, and then infuse after the high-dose chemotherapy. Plerixafor, which is a CXCR4 inhibitor, is a more recent innovation over the last 10 years or so, and that is much more effective at collecting cells that have poor collection with GCSF. So if patients are not getting an adequate CD34 count with the use of GCSF alone, then we add plerixafor, and then that will allow collection in a vast majority of patients. Occasionally, if the patient has persistent disease or difficult to control disease, we may consider using chemotherapy and GCSF together to try and cite or reduce their disease. And at the time they're rebounding with their blood count recovery, then there are a greater amount of stem cells in the peripheral blood, and we can use that as an opportunity to collect stem cells after the chemotherapy, using both the chemotherapy to, one, provide additional cytoreduction, and two is to stimulate stem cell release into the peripheral blood with the use of GCSF and chemotherapy recovery, and that will allow us to collect in patients that have more difficult, challenging disease. Predictors for collection is the CD34 is the main peripheral blood test that we use. It's much more predictive than the total white cell count. And as you can see, for our usual parameters for collection, if we're doing one transplant, which is usually 3 to 4 million cells per kilogram of CD34 cells, then 10 per microliter in the peripheral blood after the growth factor is what we would want to see as a minimum. If we're trying to collect for 2 transplants, which is often the case, then we'll try and aim for 20 cells per microliter. If we don't meet those, we'll add plerixafor. And the reason why we don't add it in everybody is that it's about $6,000 a dose. So it's fairly cost prohibitive if you use it for everybody. But if we use it in an algorithmic fashion, it works pretty well, and it allows us to collect a vast majority of patients with not everybody being exposed to plerixafor and the additional cost. Factors that affect mobilization for our autologous transplant patients are if they're older or female, there's a little higher risk of non-collection. More intensive prior therapy, especially the purine analogs such as fludarabine, or importantly now lenalidomide has got a negative impact on collection of stem cells, or prior bone marrow radiation, or a lower pre-mobilization platelet count suggesting a surrogate of bone marrow function. They all can predict for a lower chance of collecting adequate number of stem cells. At a minimum, for an autologous transplant, we use about 2 million stem cells per kilogram as a very basic level that we need in order to ensure reasonable confidence that they will engraft. But typically, we'd like to have at least 3 million cells for most autologous transplant patients, because they will be at less risk of having delayed platelet count recovery and potentially relapse as well. Plerixafor, as I mentioned, is a CXCR4 inhibitor, and that allows release of the stem cells into the peripheral circulation by binding to SDF1. It was initially developed as an inhibitor of HIV entry into CD4 positive cells, but was found to result in leukocytosis. And when it was looked into what the mechanism of that was, it was realized that it was mobilizing stem cells, and therefore became a lot more useful as a stem cell mobilizer than as a HIV drug. With the use of new HIV drugs, it's not considered as a therapeutic option, and therefore it has become a really a valuable addition to our stem cell collection armamentarium. Just switching gears slightly to allogeneic transplant. And so for patients that are being considered for an allogeneic transplant, one of the challenges becomes whether they have a potential donor or not. In general, people are often asking, what's the chances that my sibling will match? And if they are a full sibling, all other things being equal, with the same parents, both mother and father, there's about a 1 in 4 chance that they will have a HLA identical sibling, about a 2 in 4 chance that they will have a half-matched or haploidentical sibling, and then there's about a 1 in 4 chance that they won't match at all. From the purposes of transplant, a full match sibling is our first choice. For many diseases now, we do consider the use of haploidentical or half-matched or 5 out of 10 matching, and that can be a very valuable option, and I'll talk a little bit more about how that's developed over the last few years, but that has become a very useful addition to considering for allogeneic transplants in family members. What is the likelihood of us finding a donor in the registry? That's a frequent question that comes up as well, and it is quite strongly linked to ethnicity and heritage. So as you can see, based on a couple of factors, one is the representation within the unrelated donor registry, the Vita Match registry, and also the diversity of different ethnic groups. So for instance, African Americans have much greater diversity of HLA types, whereas Caucasians have a much more restricted diversity. And so therefore it's quite a lot more likely that we would find a full match for a Caucasian recipient of Scandinavian or Western European heritage, and you can see up to 80% chance that we'd find a fully matched donor in the unrelated donor registry there. Whereas if we have somebody from the Pacific Islands or African American, the chances become much less likely that we'll find a fully matched donor in the registry. So this is why it's important that we have options such as haploidentical transplant or mismatched unrelated donor transplant, and I'll talk a little bit more about what our options are there to expand the potential pool of donors for our recipients that need allogeneic transplant. Just a brief word on what's happening with trends in allogeneic transplant. Here you can see what's happening with age. And so as you can see, up to a quarter of patients in the last couple of years are over the age of 65 receiving allogeneic transplant. And that's quite a remarkable change. 20, 30 years ago, if you're over 35, you were considered to be high risk for allogeneic transplant. But more recently, with a combination of better supportive care, better antifungal medicines, reduced intensity conditioning with the onset of purine analogs, all of this has allowed patients that are older in their 60s and sometimes 70s and possibly even older to be considered as potential candidates for allogeneic transplant. And this is important because a majority of our diseases are kind of median age of presentation is in their mid-60s. And so having a strategy that excludes most people over the age of 60 isn't entirely helpful. But with newer targeted therapies and with advances in reduced intensity allogeneic transplant, this has allowed us to consider some of these patients are a much greater percentage of patients for more intensive therapies safely. What's happened overall with the potential types of donor that we consider? Here you can see the green line, which has showed a remarkable increase over the last few years, and that's essentially haploidentical or half-matched family transplants. And as you can see on the light blue line, the number of cord blood transplants is reducing or declining gradually. And this is because of a seminal study that was recently published that suggests it compared directly cord blood to haploidentical transplant, and it showed that the survival and outcomes associated with haploidentical transplant were slightly better compared to cord blood transplant. And in fact, it tends to be cheaper as well because the additional transfusion requirements and cost associated with collecting and storing cord blood tends to be significant. So this has allowed haploidentical transplant from family donors to become much more attractive as an option, and you can see that trend represented in the national numbers as well. Why has haploidentical transplant become an option? In the past, we used to CD34 select. So we would take out the T cells and just use the CD34 cells, which are the stem cells. And the challenge with that was that we didn't provide them any T cells, then they were at very high risk for getting secondary infections, such as viral infections, particularly T cell controlled infections, and also viral-driven malignancies. So EBV associated post-transplant lymphoproliferative diseases were all very common in patients that had no T cell add back, but were just given CD34 selected cells. So that became a very risky option with a high mortality, and that fell out of favor. But the development of post-transplant cyclophosphamide, which is able to selectively eradicate T cells that are driving graft versus host disease while relatively preserving antiviral and anti-infectious T cells, has really transformed the field. And this allows us to consider doing much more mismatched transplants relatively safe. And many of these patients don't develop severe or very difficult graft versus host disease, but they still have preserved immune competency, especially against viral infections. And that has made this a much more attractive option. And so that's become the standard now for haploidentical transplant, is using post-transplant cyclophosphamide, high doses of cyclophosphamide, days 3 and 4 after the transplant. And so that is actually becoming equivalent to the use of a fully matched unrelated donor or a matched sibling donor for many diseases, especially those when they're in remission. What about the use of peripheral blood versus bone marrow-derived grafts? Well, in fact, there was a large study, again, that looked at this question, and you can see the publication there, that looked at peripheral blood versus bone marrow. The bottom line was that the survival for patients that were in leukemia in first remission or second remission, but not with active disease, had equivalent survival. The overall survival was not statistically different, as you can see here, but there was a significant difference in outcomes. And those patients that had bone marrow-derived graft had a little higher risk of graft rejection. So for those patients that might be at greater risk of graft rejection, if they have donor-specific antibodies or splenomegaly or bone marrow fibrosis, then we would lean towards considering peripheral blood as an option. Those patients that got peripheral blood had a worse quality of life overall as a result of chronic graft versus host disease. So unless a patient has a greater risk of bone marrow of rejection, we would generally lean towards considering a bone marrow-derived graft rather than peripheral blood-derived graft for an unrelated donor transplant for patients that are in remission. Now, in theory, that's what should be happening, and we try to do that. But when you look at the field, you can see that still a majority of transplants are done using peripheral blood-derived grafts. And some of this is based on their underlying disease and the necessity to do that. But to be honest, some of it is related to just the convenience of collecting peripheral blood, which is a lot easier than collecting bone marrow harvest, which involves the operating room and a lot of logistics. So unfortunately, some of this is probably not science-driven, but is driven by convenience and logistics, which is not obviously the right thing to be doing. But for a majority of patients, peripheral blood is still the primary graft. Now, there are legitimate reasons to choose peripheral blood for many of these patients, but probably less so than is represented in this graph. A little bit on the, what do we need to do to select unrelated donors for those patients or those providers that are in other solid organ like nephrology, and they are looking at picking out donors for kidney transplant. It's similar but not identical. In bone marrow transplant, there is much less of a focus on ABO mismatching, which is critical in solid organ transplant, and a much greater focus on HLA matching, which is less critical in solid organ transplant. So for us, HLA matching is the number one thing that we look at. And as you can see, if we can get a 10 out of 10 or 8 out of 8 at a minimum match, that would be considered our initial baseline standard. For reference, if you have a 7 out of 10 mismatched unrelated donor, there's about a 10% drop in survival for every mismatch that you get beyond 8 out of 8. And so we do really try to avoid mismatched transplants with standard conditioning regimens. Donor age is actually quite important, and a difference of a decade in the donor age can have a significant impact on outcome for recipients. So we do try to pick the youngest donors. Usually most donors in the registry tend to be in their 20s or 30s, and so it's rare that we would go to picking a donor that's over 50 in the unrelated donor registry. For sibling donors, however, many of our patients, as you know, present in their 50s and 60s and 70s, and so therefore their siblings are also of similar age, and so we have a much greater age for our sibling donors than we do for our unrelated donors typically, because for unrelated donors, a lot of the people in the registry are less than 60. That's a requirement from the registry when they sign up, and we end up picking by necessity a lot of younger donors. HLA DP, B1, and DQ are less important, but becoming more so as we get more and more precise matching. And so we do try to get permissive matching for HLA DP, B1, if we can do that. And then there are some minor HLA antigens like DR beta 3, 4, and 5, which are not associated with a survival disadvantage in isolation, but in combination with some of the other mismatches, they can be additive or maybe even synergistic. Donor-specific antibodies is of critical importance, and depending on the level, this can preclude proceeding with a transplant. So if a patient has anti-HLA antibodies to their donor, it's very much dose dependent, and so if it's less than 1,000, generally we can proceed without any additional intervention. If it's over 5,000, generally that's associated with a very high risk of graft rejection, and something needs to be done. Choosing an alternative donor is the easiest and best if it's available. If not, there are ways to try and desensitize and remove the donor-specific antibodies that are challenging but can be done in selected circumstances. And then the transplant center practice may vary a little bit. It depends on what the area of expertise is for the transplant center, and some transplant centers will pick unrelated donor options over cord blood options. It depends a little bit on their local expertise and kind of research interest and all of that. But there are options available to us from sibling donors, mismatched sibling donors or family members, unrelated donors, and then haploidentical transplants, and finally cord blood transplants, depending on the circumstance and the specific needs of the patient and the mismatches that are present. Just to switch gears a little bit then into disease-specific focus. So a majority of allogeneic transplant, which I'll focus on now, is for acute leukemias, myelodysplastic syndrome, and bone marrow failure syndromes. And in the past, 20 years ago, we had a very simple algorithm for what was high risk and what was standard risk based on cytogenetics, standard cytogenetics. But this, as in all other areas, has exploded with the advent and recognition of additional molecular phenotypes. And so this allows us to further stratify diseases into intermediate, high, or low risk based on their standard chromosomes, but more importantly, the next generation sequencing panel and specific molecular mutations. And this is not to memorize, but to just kind of get a sense of. There are some patients like those that have a monosomal karyotype, which is the presence of one monosomal chromosomal abnormality plus some other cytogenetic abnormality. That can be associated with a 4-year survival of less than 5% if you do not have allogeneic transplant. And so that obviously is something that we would really focus on. Unfortunately, even with allogeneic transplant, those patients have a very high risk of relapse. On the other hand, there are some of these drivers that are associated with good risk, and that allows us to consider a non-transplant approach in first remission. However, if they relapse, then usually they're not considered good risk anymore, and then most of those patients might be a candidate for allogeneic transplant. But this gives an idea of the rapidly evolving nature of choosing transplants for these patients and newer areas that are being developed, and we recognize the importance of some of these mutations over time, and so that can lead to some evolution in our approach. But for the most part, this provides the baseline that we go from. The European Leukemia Net has provided a risk stratification based on the most common mutations and the most important, and this is available in the slide set, I think, that you're getting as well if you are interested and involved in treating these patients. So overall, the bottom line is for acute myeloid leukemia, the types of patients that might be a candidate for allogeneic transplant are primary induction failure. Now, this is a very selected circumstance. So they're not the patients that are totally refractory to chemotherapy, but those that have quite good cytoreduction but not achieved a complete remission. And are young and maybe a good candidate for a myeloablative conditioning regimen and don't have a very high risk molecular phenotype like a monosomal karyotype, because those patients will inevitably relapse if they're not in remission and they undergo a transplant with active disease at the time of transplant. But something to think about for selected patients, there might be a 10 to 15% long-term survival for primary induction failure if they meet the right criteria. Patients that are in first remission, we consider pretty much most of those patients, unless they are considered favorable risk, which are the core binding factor mutations. So translocations of 16 or 821. Again, some molecular phenotype like an isolated biallelic CBP alpha mutation. So this kind of tells us the importance of cytogenetics and molecular characterization of these patients in determining whether they would benefit from allogeneic transplant or not. The other patients that we consider are even those that might be considered good risk if they remain minimal or measurable residual disease positive after their initial therapy, then that's a predictor for relapse for many of these patients, and therefore we might consider those for allogeneic transplant, whereas they may not have met the initial traditional higher risk or intermediate risk factors. And then if they have high risk factors like preceding myelodysplastic syndrome, or if they have developed therapy-related leukemia, for instance, if they had previous breast cancer or lymphoma, and now they've developed a leukemia or myelodysplastic syndrome, those are by definition high risk, and then we might consider those even if they've had excellent response to initial standard chemotherapy. So what is the survival for patients with acute leukemia? So for AML, here you can see the differences between matched related donor and matched unrelated donor, not dramatically different, but what is important is whether they go to transplant in remission, or if they have never gotten into remission, or if they have active disease at the time of transplant. You can see a substantial difference in outcome. But some of those patients that were never able to achieve remission can achieve a long-term success, 5-year survival, in about maybe 20 to 30% of cases if they have not achieved complete remission. But that doesn't mean 80% blasts or active disease. Unfortunately, that means that they are not quite able to completely eradicate their disease, but are chemotherapy responsive typically. Just briefly, is there a difference between myeloablative and reduced intensity? What is myeloablative? Well, myeloablative is essentially the highest dose of chemotherapy we can get by with without causing a high risk of serious injury to other organs apart from the bone marrow, so heart, lungs, kidneys, etc. And so in that way, we intensify the chemotherapy or radiation therapy to the maximum, and then give them their stem cell product back to recover their blood counts. Reduced intensity is where we're relying mostly on the immune system of the donor, but not on the intensity of the chemotherapy. And there's a role for both. For patients with, and this looked at a group of patients that were in their mid-50s or so for the most part, that might have been a candidate either for a more intense or less intense regimen. They were generally very healthy patients. And it turned out that those patients that had a myeloablative or a more intense regimen actually had a better outcome and an overall better survival if they had acute myeloid leukemia in remission, but higher risk with the more intense regimen. Now, if they're not a candidate for an intense regimen because of comorbidities, obviously that's not relevant. But in those patients that were able to be a candidate for either, then there is some advantage in acute myeloid leukemia to giving a more intense regimen as distinct from other diseases like CLL, where that's less clear-cut. Acute lymphoblastic leukemia, we can see a similar pattern. We use allogeneic transplant for primary induction failure in selected circumstances again, and now with newer strategies to treat this, like CD19 directed therapies, CD22 directed therapies, then we can achieve a good cytoreduction for a good, much greater percentage of patients. And also we can use that as a way of trying to salvage patients that have early relapse after transplant. So this has opened up the indications for allogeneic transplant with some of the newer targeted therapies quite a bit. And this obviously gets into the whole area of CAR T or cell approach, which also is a way of targeting specific markers on the lymphoblast, such as CD19, with T cells that are directed towards the leukemia. Obviously, CAR T has been quite dramatically effective in treating relapsed acute lymphoblastic leukemia with up to 80% response rates. There are failures because of a variety of mechanisms, but this has also allowed us to consider a greater percentage of patients for allogeneic transplant, or even as an alternative to allogeneic transplant, depending on the circumstances. Again, what are the outcomes for in patients with acute lymphoblastic leukemia? Here you can see again what the survival looks like. There's a much greater chance of having long-term survival in first remission for patients with ALL, and we'll consider a majority of patients for transplant, unless they have had a really excellent minimal residual disease negative response early on, then they would generally be a candidate, even if they're considered standard risk for patients with acute lymphoblastic leukemia, because that tends to be high-risk disease. There's no good risk category for ALL in general. It's all standard risk or high risk. Myelodysplastic syndromes, again, briefly touching on this, but again, allogeneic transplant for those patients that are intermediate to high risk is our usual approach, or if they have additional prognostic features that are suggesting higher risk. We won't go through all the details here, but you can see, generally speaking, if they have very indolent disease, they're predicted to have maybe up to a 5 to 10 year survival without transplant, then we will wait on considering transplant because of the transplant-related toxicities. But if they are moving on to intermediate or high risk, then we would try and do the transplant before they are at greater risk of developing acute leukemia and then not having a successful outcome with regard to transplant and disease control. CML, again, one of the success stories in hematology. So it's rare that we have to consider moving down the road of transplant for CML anymore in view of the tyrosine kinase inhibitors. There are some selected situations even today where we consider allogeneic transplant for CML, and that's in cases of true TKI resistance, where they are developing mutations that predicts for resistance to multiple TKIs. Even for some of the mutations, for instance, T351I mutation that can be targeted by drugs such as ponatinib. However, that is associated with some significant challenges, including thromboembolic manifestations. And there are newer drugs that are now using a different mechanism that is likely to be FDA approved later this year, which may also be able to target patients that have T315I mutations as well. So there are other strategies coming, but we reserve allogeneic transplant for patients with CML to a small subgroup of patients because the vast majority are controlled or cured with TKI therapy at present. So thankfully, much less transplants for CML today. Myelofibrosis, again, we base the role for transplant based on the risk of the disease, and if they have intermediate or high-risk disease based on the scoring system, which is called the DIPS scoring system, then that will determine who might benefit most from transplant. And that's based on what their blood counts are, whether they have increasing blasts in the blood or in the bone marrow, and whether they have complex karyotype, whether they are transfusion requiring, or if they have high-risk driver mutations as listed here, then all of those things factor into whether they might benefit from an early allogeneic transplant or benefit from a more conservative approach initially. There is no curative treatment short of transplant for myelofibrosis or most chronic myeloid disorders. So it's really a question of balancing what their likelihood of having a bad outcome in the near future is compared to the risk of allogeneic transplant, and whether they might do well with conservative treatment, which is non-curative but able to manage their disease. And many of these patients, or some of these patients, don't even need any treatment at all. They may have quite indolent disease and can go for a number of years without any specific therapy. So if it's somebody like that, then they may be better off with just observation or kind of less intense treatment, whereas the patients that are young and have a high-risk disease that's likely to transform to leukemia in the short term, they're the ones that benefit most from allogeneic transplant sooner rather than later. CLL, again, is another disease that the number of transplants has dropped dramatically for over the last number of years, and that's again based on a number of new targeted drugs such as ibrutinib and calbrutinib and venetoclax, all which have transformed the treatment of CLL. So it's only a small minority of patients with higher risk disease and Richter's transformation that end up undergoing allogeneic transplant today because of the plethora of non-transplant new therapeutic options that have become available for these patients. Aplastic anemia and bone marrow failure syndromes, again, briefly to touch on, for those young patients less than 18 that have severe aplastic anemia defined by a neutrophil count less than 500, or very severe aplastic anemia defined by a neutrophil count less than 200, generally we consider allogeneic transplant as the treatment of choice for those patients up front. And they can have an excellent outcome with greater than 90% survival, and many times without a lot of downstream secondary malignancies. And so that is a good option for many of these patients up front if you have a well-matched donor before they start developing complications of their aplastic anemia. For reference, in 50 years ago, if you had aplastic anemia, severe aplastic anemia, there was like a 90% mortality or something like that. So this disease has been transformed by the combination of current non-transplant approaches for those patients that are lower risk and allogeneic transplant for those that are high risk. And you can see the outcomes here are really quite excellent from an allogeneic transplant standpoint. This is about as good as it gets. Treatment of aplastic anemia is very much age dependent, both for transplant and non-transplant approaches. And here you can see the difference in outcome based on if you present at age 20 or if you present at age 60 or 50. And generally speaking, younger patients do better, they tolerate treatment better, and they may be more responsive, and they're maybe more likely to be immune mediated in the first place, whereas some of the older patients may have other underlying stem cell problems that are leading to their blood counts, and they may be diagnosed as aplastic anemia, but it may not truly be immune mediated. I'll just skip over this for now. So this is a useful slide from me for trying to determine who might benefit most from immunosuppressive therapy for aplastic anemia and who might benefit most from transplant. And so here you can see, based on what the neutrophil count is, if you have profound neutropenia as determined by the red arrow, or if you have, and if you're younger as determined by the blue arrow, you can benefit from transplant. So you can see the red 24 is the patient that will benefit most from transplant. So if you're age 10 and you have a neutrophil count of 0, then you're going to really do well with allogeneic transplant compared to immunosuppressive therapy. On the other end of the graph, you can see if you're age 50 and you have a neutrophil count that's moderately, 0.5, which is not as severely low, then you have a much more likelihood to benefit from immunosuppression. And so you can kind of see where this all balances out. So younger and more severe disease, allogeneic transplant; older and less severe disease, then immunosuppression, and kind of all shades of red or blue in between. I'll skip that for now. Just a brief note on bone marrow failure syndromes, because this impacts many areas now outside of hematology. So it affects nephrologists, hepatologists, pulmonologists, because many of these disorders have multi-system involvement. And so it is something to be aware of. So if you're in the pulmonary clinic and you're seeing IPF, then it's always important to bear in mind, is this something that could be related to a telomere disorder? Because many of those have lung fibrotic states. Similarly, if you're seeing cirrhosis in the hepatology clinic, many of the patients with telomere disorders do have hepatic fibrosis and cirrhosis over time. So having a kind of a high index of suspicion for some of these disorders is key to making the diagnosis. It's not always clear, but we're beginning to understand more and more the multifarious manifestations of many of these diseases. So just to have it on your radar and see them and be aware that they're out there for bone marrow failure syndromes associated with some other disorder, pancreatic insufficiency or pulmonary fibrosis or cirrhosis, then you may start thinking, is this something more than just aplastic anemia, and is it truly an inherited bone marrow disorder along the lines of dyskeratosis congenita or Fanconi? Just briefly on some of those disorders, Fanconi anemia, many times they don't have the classical physical stigmata that's kind of listed in the textbooks, with musculoskeletal changes, extra ribs. Most of the ones I've seen in their 40s and 50s have very minimal, just maybe a small misshapen thumb or an extra rib or something that's really quite unremarkable unless you're specifically looking for it. But DEB, dietoxybutane testing, will be abnormal, and there are a number of tests there that can confirm if you think that you have somebody with Fanconi anemia. Similarly, dyskeratosis congenita is a shortened telomere disorder associated with nail dystrophy, leukoplakia, kind of pulmonary fibrosis, liver fibrosis. Again, high index of suspicion. There's a classic rash that goes along with that. So if you've seen it once, you maybe recognize it again and be able to kind of think about this. And the reason these are extremely important is if you give standard chemotherapy to these patients, they will have extreme toxicity and die as a result of profound aplasia and lung injury and liver injury as a result of the intensity of chemotherapy, because they do have a DNA mismatch repair problem, and that leads to much greater toxicity. So having a high index of suspicion of these before you treat them with high intensity chemotherapy is extremely important. Just briefly to see some of the manifestations, for instance, dyskeratosis congenita, you can see here the classic reticulin type rash on the picture on A. There are tongue manifestations, genital manifestations, nail dystrophy. All of these can be hints, and premature graying of the hair is another hint that sometimes is quite useful, or a leukoplakia. So any of these things in addition to their bone marrow failure syndrome would make you more suspicious, even if it's not a young patient, even if they're in their 50s or 60s, we can see that with a milder phenotype sometimes. I'll skip that. How do we test for that? One is telomere length assessment, and if it's less than the first or second percentile, especially in the lymphocytes, the granulocytes is not as predictive, but a lymphocyte, for instance, in the second panel, you can see where the red diamond is. That's very strikingly associated with a telomere disorder. When you're down in that level of percentile in lymphocytes, then we start working them up for a telomere disorder like DKC or dyskeratosis congenita, and more common than you might expect. And we missed a lot of these in the past, and we're trying to tune into it more so that we pick them up and manage them correctly because they're so vulnerable to toxicities. Again, just a brief note on GATA syndromes. Some of the things to bear in mind, these can be associated with HPV-driven warts. So if you have a patient with a bone marrow failure syndrome and a lot of warts, then that may suggest an underlying GATA2 syndrome. Again, disseminated mycobacterial infections are common in these patients because of the difficulties with monocyte function, B-cell lymphopenia, NK lymphocyte defects. So all of these might be hints that there's something more going on and may trigger an assessment for a bone marrow failure syndrome that's genetic or inherited. I'll skip that for now. So just briefly, tools for assessing disease risk. So we have for leukemias and for many other diseases, lymphoma, multiple myeloma, many disease-specific tools that determine their risk for progression. And in those patients, we use the specific tools. But for allogeneic transplant in general, we also have a disease risk index, which categorizes patients into general categories of low, intermediate, or high risk. And that helps us determine whether a good candidate for a transplant or not. We also look at the comorbidity risk. And essentially, this is like the old Charleston comorbidity score, but it's modified and refined for bone marrow transplant. And so that looks at what their other organ function is. Do they have significant heart, lung, psychiatric, or hepatic dysfunction that might increase their risk? And based on that comorbidity risk, then we can determine what their likelihood of transplant-related toxicity is. And then finally, a very important part, is everybody who's seen an allogeneic transplant recipient would know, it's an extremely arduous undergoing. And so we do have a psychosocial assessment to see if they have the resources in order to be able to relatively likely get through this safely and effectively. We don't want to put somebody that doesn't have those resources through it and have them have a bad outcome as a result of that. So a psychosocial assessment is also a critical part of our assessment of these patients. The DRI, you can put this on an online calculator and it will tell you exactly what your disease risk is. For instance, they looked at mantle cell lymphoma, partial remission, and it puts you in an intermediate DRI risk group. And so at the end of the slides, I think there is a couple of resources that would be helpful for determining that for each individual disease. Leukemia, lymphoma, everything is included there. The DRI is important as regards the outcome. Here you can see the overall survival when we have patients that are undergoing allogeneic transplant. If they are low risk, much better outcome than if they're high risk. Somewhat intuitive, but still important when you're factoring in both their risk of their disease and their comorbidities and their psychosocial situation. What's the likelihood of them having a successful outcome? Again, looking at individual organ function is fairly important, and here you can see the impact of significant lung dysfunction on the outcomes after allogeneic transplant, and that's factored into the comorbidity score. Here, looking at a combination of all of the various organ systems, and it gives us a weighted score at the end. And if you have a score greater than 4 or so, then your likelihood of transplant-related morbidity or mortality is in the range of around 40+%. So that's very predictive for outcome. And so we factor this in with their disease risk to determine, who's a good candidate for transplant. Here you can see again what the non-relapse mortality, or basically the toxicity of transplant, is, and the overall survival based on what their comorbidity score is. And the bottom line is the more comorbidities you have, then generally speaking, the more likelihood of poor outcome, especially after myeloablative conditioning. You can get away with more comorbidities with a reduced intensity conditioning regimen if their disease is likely to be sensitive to the graft versus leukemia effect. If it's a disease that's not generally sensitive to graft versus leukemia, then reduced intensity, which relies very little on the intensity of the chemotherapy and very heavily on the immune system of the donor, is not a good option for diseases that don't respond well to graft versus leukemia effect. And diseases like that would be, for instance, melanoma, and has been tried, and they have some graft versus melanoma effect, but that was not sufficient to justify continuing. And there were some initial trials in solid organs such as melanoma and kidney cancer, and there were some notable responses, but overall it's not a great strategy. So diseases that have a very good graft versus leukemia effect are diseases like chronic lymphocytic leukemia and CML, both of which tend to respond well to the immune system of the donor. Finally, the goals of psychosocial assessment is to really, one, determine the right patient for transplant, but also to promote fairness and access to care and make sure that we're not unnecessarily biasing patients not to be able to go ahead with transplant, but at the same time, give them a reasonable chance of being successful, because the rigors of transplant can really unmask a whole host of challenges in the psychosocial situation that can sometimes be addressed and sometimes really lead to a very disastrous outcome. So we want to be sure we understand that fully before committing to doing that, both for primarily for the patient's perspective, but also to make sure that we're really doing the right thing with our resource utilization. The SIPAT score is from Stanford, and this has been developed in solid organ transplantation predominantly, but is also helpful in the bone marrow transplant realm. And so this looks at a combination of the patient's readiness level, understanding of the disease, social support, psychological stability, whether they have substance abuse issues, and kind of what their overall scale of readiness is for allogeneic transplant based on that. And here you can see, if our social workers run this tool, and if they look at it, then you can see what their various different scores are and the components based on what the issues they have with regard to their understanding of transplant, social support, and substance use. And then we give them a final score, and that tells us, for instance, a score of 44 makes you a poor candidate. Doesn't mean it's an absolute no, but we do have to factor that in when we're thinking about whether it's the right thing to do for the patient or not. So finally, these are some resources that I think might be helpful. B.Ch has a lot of information also on who the right patients are to consider for transplant, but also for how do we manage and provide appropriate survivorship care to the patients that are post-allogeneic transplant. So there's a huge amount of information there about what's the right follow for thyroid function testing, for lung function testing, for management of chronic graft versus host disease. So if you're a primary care physician or in a non-bone marrow transplant area, there's a tremendous amount of information on this website that kind of helps you tailor the ongoing survivorship management for patients that aren't directly being followed by bone marrow transplant, but may have had a previous transplant 5 or 10 years ago. ASTCT also has a lot of indications for what are the practice guidelines, and as they evolve, they update that. And so that gives you a good resource for indications for transplant. If you're looking for an online HCTI calculator, this one is excellent. And this was developed by Mohammed Saror from Seattle, who has really presented a lot of the literature on the HCTCI, and this has become standard in transplant for determining their comorbidities and risk score. So I'll stop there, and I'll just kind of open it up to any questions or thoughts or anything that I didn't cover that people are interested in. I'd be happy to try and address. Thank you. So I don't see any questions coming up. If there are, then please feel free to speak up. I think from the standpoint of transplant, if there's anything that we can kind of assist with, if there are patients that are questionable candidates for transplant, or if you think you need to consider kind of a delayed or more urgent assessment for transplant, we're happy to try and help facilitate that at any time. So if there are anything we can do, or if there's post-transplant kind of management issues with survivorship, then we're happy to try and help with that as well. So feel free to reach out to us, at any time if we can be of help in kind of managing these patients, either pre or post-transplant.
All right, thanks. And thank you for presenting.
Thank you very much. It was a pleasure.